Respected speakers, distinguished speakers, and Ayurvedic practitioners, I have come here to enlighten about the severity of rheumatoid arthritis, which is very much prevalent in our country. And though I am an orthopedic professor, I was instrumental in starting a rheumatology division in CME hospital, Coimbatore, because in day-to-day practice we encounter a lot of arthritis patients, especially knee joint. So about 30 to 40% of arthritis is mainly involving the knee joint because it is the weight-bearing joint. So I have found out among the arthritis, we prefer to diagnose only on clinical basis because in government setup we may not have adequate facilities for doing all laboratory investigations. So we go by clinical practice. And as the previous speakers have enlightened about the importance of treatment before it catches the joint. As you all know, there are two components in the joint. One is articular cartilage and the other is synovial membrane. The articular cartilage is not vascular and it is not supplied with nerve endings and it is devoid of lymphatics. Whereas the synovial membrane is highly vascular and it is more sensitive to pain. That is the reason before the articular cartilage gets destroyed, we have to catch up the diagnosis and treat energetically. And our practice, the commonest ratio is female-male ratio is 3:1. And Dr. Vasudevan's observation is 2:1. And it commonly affects the third decade. And especially what made me to take up arthritis about 28 years ago when I was a student in Madras Medical College. One family lady, aged about 35 or so, came as soon as I asked her to sit down. Usually I was going from FSL, that is from Pollachi area. I went to Madras Medical College. You know the way in which we respect patients, that the respect in Kungunadu, which comprises Palakkad adjacent district also, we are very friendly with patients and we respect them. And when I was there in the OP and I asked her to sit, the moment I offered a seat and asked her grievances, as Dr. Bhaktavachalam was telling, we have to deal the patient as our relatives. What is your problem? So she started weeping. My husband says, செத்து தொலைய மாட்டேங்கிற காலங்காத்தால எந்திரிக்க மாட்டாங்க ஒரு காஃபி போடுறதுன்னா கூட முடியல. She is not capable of getting in the morning. Why the sun is coming up? The early morning stiffness which I have found in that patient. Stiffness is more, and especially during winter it kills the patient. So her tears made me to do something good to the society. We have to explore the rheumatoid arthritis. If you carefully see, there are about 4 or 5 rings, which is not very clear here. See, these are all the branches of medicine: Ayurveda, Unani, Siddha, Homeopathy, and also Allopathy. Whatever may be the medicine, I am open to accept the treatment offered by all the branches, just to save the humanity from crippling the disease. The disease is almost cripples. Life is movement, and movement is life. It totally cripples the patient. So the articular cartilage has got a 3 strata. First second and third. First layer is very much mildly active. Second and third is more active and produces chondrocyte. And it has got a proteoglycans, a core protein, and a glycans, glycosaminoglycans. Glycosaminoglycans, again it is divided into chondroitin 4-sulfate, which is very much found in embryonic age, chondroitin 6-sulfate, which is found in adult, and keratosulfate, which is found in the elderly. And the synovial membrane has got 65% of subsynovial tissues, which contains mast cells and this type A and B cells. And it has got lot of capacity to regenerate, and it is vascular, highly vascular, as Dr. Vasudevan was putting in his slide. They apply some leeches. The basis behind applying leeches into the inflamed joint, whether it is rheumatoid arthritis or osteoarthritis, is it decompresses the joint, that gives pain relief. As you know, the leeches, when it is applied to a human body, it secretes an anesthetic, and without your knowledge it drops away all the blood. Similarly, you will not feel the pain whenever the joint is decompressed. That is the rationale behind the leech application, which is also a traditional medicine in Ayurveda. And sometimes in allopathic practice, whenever a patient comes with severe pain with osteoarthritis, we apply local anesthetic just below the knee joint, that is in the tibia. We apply a wide bore so that the blood oozes out. Once the tension is relieved, the pain also gets relieved. That is the basis behind this leech application and applying a needle in the knee joint, just below the knee joint. Whenever the joint is inflamed, it produces exudate, it enlarges the joint cavity distance, so that the position of ease is flexion. When you flex, it accommodates more fluid. That is the reason it is kept in flexion. Any attempt to extend the joint will provoke pain. So that is the reason we give night splints in a flexed position. And sometimes we give analgesics, muscle relaxant. As I said in the outset, that lady was crying, so she gets terribly upset. So there comes the element of mood elevators, antidepressant. We give antidepressant also. And this synovial joint, once destroyed, it goes into so many degradation. The joint gets swollen, and the synovial effusion distends the joint, and the patient is not able to do his routine movement. Whenever there is a synovial proliferation, as Dr. Gopakumar has put it in the slide, is pannus formation. The pannus formation, synovial proliferation, you will feel clinically a boggy swelling, especially felt in the medial aspect of the knee joint, sometimes in the lateral aspect of the knee joint, a boggy swelling. Because of the inability to extend, the muscles are kept in flexion, the muscle goes for atrophy. Any joint, any motion, it's not used properly, will go to atrophy. And you all know it is easy to add weight. Fat deposition, you can within 1 month you can improve your weight with fat, but it is very, very difficult to shed the fat. Similarly, the muscle mass, if it is immobilized, we see in lot of orthopedic cases, fracture patient, if you apply POP and if you have not properly educated the patient about the importance of static quadriceps exercise, the muscles will go for wasting. and it is very difficult to regain the muscle mass. And all of you will agree that muscle mass, especially vastus medialis muscle, that is just in front of the knee joint. This is the vastus medialis muscle, which shows the first sign of atrophy. You can compare the knee joint. The disease activity, as you all know about the signs of inflammation. You can, with the back of your hand, you can touch the patient's knee and you can perceive clinically whether the disease is active or not. We are not very much dependent on laboratory investigation. Sometimes it may be positive, especially rheumatoid arthritis factor and CCP and CRP, ASO will be elevated in so many other diseases. It's very difficult to distinguish between osteoarthritis and rheumatoid arthritis. Sometimes chikungunya, recently from Kerala, adjacent district of Palakkad, Pollachi, we get lot of chikungunya patients. That is one source of etiological factors in rheumatoid arthritis is this arbovirus. Arbovirus group of infection can lead to these things. And certain drugs like Salazar, that is used in ulcerative colitis, is used in rheumatoid disease as a disease modifying anti-rheumatic drugs. See, because of these reasons, though it is an autoimmune disease, the body recognizes it as a foreign body and it starts doing this antigen antibody reaction, and you have this increased titer of gamma globulin, especially IgM. So this is the normal joint space, what you see on this side, left side, and the right side. The joint space in rheumatoid arthritis gets reduced, and if you see in the X-ray, as well shown, you will have periarticular osteoporosis just adjacent to the joint. Because of the immobility, because of the attachment of the capsule, it goes for osteoporosis. And the severe, the minimal periosteal osteoporosis is tolerated, and it can be back to normal. You can reverse the normal physiological status. Once it erodes the joint fully, if the joint is subluxated, and it is very, very difficult to regain to normalcy, and that is not possible. Our other clinical presentation is already talked. These are all the commonest joints. Elbow joints are not so much involved. Elbow joints are rarely involved. Similarly, you can have acromioclavicular joint as an isolated entity of rheumatoid arthritis. Even though, according to ARC, you have to have at least minimum 1 to 4 criteria. Very rare presentation, atypical presentation we also come across in clinical practice. Isolated sternoclavicular joint swelling, and it is very, very common. The only thing is, it is auto remission. It is having an history of remission and exacerbation. Remission, it is confirmed only by synovial biopsy. If you take up the knee joint, how many of you is well aware of the knee joint lubricant fluid, that is hyaluronic acid? How much will be the normal concentrations in a knee joint? Anybody? 1 ml. Yes, very good. 1 ml, 0.5 to 1 ml. What is the normal weight a knee joint transmits? A normal knee joint, aged about weighing about 65 kg. 65 kg, a normal joint, a human being weighing about 65 kg, and the knee joint supposed to carry how much weight? It is around 3.03 times. That is around 200 kilos. How is it possible? Because of the dynamic forces, muscular forces. So the muscular forces play a vital role, and the movement is playing a vital role in this. These are all the other joints. And sometimes you will have the wrist joint involvement. If there is synovial proliferation, you will end up in carpal tunnel syndrome. We do a flexor retinaculum divide so that it is given some sort of relief. The main treatment for rheumatoid arthritis starts at the synovial side. We have to reduce the synovial swelling by way of putting the patient on DMRDs. Meanwhile, though it will take 2 to 3 months minimum, so we have to immediately put them on ordinary NSAIDs. And all of you know that we have about 110 crores. 110 crores. God has created 110 crores different type of human beings. Even identical twins cannot have the same thing. Even the mother will be able to appreciate the difference between the two. So when that is the case, you cannot categorize a patient treatment accordingly. This is the treatment, you cannot say. It is tailor-made according to the different social status and economical background and the capability. As Dr. Gopakumar said, everybody cannot afford to have a knee joint replacement when the boy has got nothing to eat. Nothing to eat next time. He cannot go for a commode type of toilet. When that is the case, it's very, very difficult. So with minimal expenditure of medicines, we can always treat a patient of rheumatoid arthritis. The entrapment syndrome, the other deformities the previous speaker Gopakumar has nicely highlighted. These are all the deformities. Apart from ESR, CCP and ASO titer, we clinically do a test, aspiration of the joint. In the clinical OP we do it. As you all know, there is minimal fluid in normal joint which you cannot aspirate. In osteoarthritis, the synovial fluid is very much viscous. It is very viscous. You can feel it in the gloved finger. You can see it is very much viscous and it is almost colorless. If it is rheumatoid arthritis, it is a clear yellow solution, yellow, clear, and the amount will be more and it is less viscous. And if you see the cell count, it is ranging from 2000 to 75,000. And you can see in seronegative, the synovial fluid will be very, very cloudy synovial fluid, seronegative. These are all the clinical diagnoses which we do it in clinical, and we rarely depend upon laboratory investigations because of the availability. In private practice, we can do so many things. IgM is commonly elevated in rheumatoid arthritis, and you do genetic type HLA DR4, and you can see HLA B27 in ankylosing spondylitis. These are all very, very easy to detect and say, but it is only available in private practice outside. It's not in government service. Extra-articular manifestations of rheumatoid disease, though it is called autoimmune disease, it involves all the systems. For example, it involves the elbow. Very rarely, because of the advent of medicines, the patients across the table, they get the medicines. You need not prescribe, I need not prescribe. They go and ask something because in our country everything is available. If you go to adjacent countries or European countries, without prescription you cannot. You cannot. Recently I had been to Bangkok. I was asking for I was suffering from respiratory infection. I was asking for azithromycin injection and tablets. They said it's not available, only with prescription. So they have that system. And in Tamil Nadu, you just come across spurious drugs. There is no sincerity. See, whether somebody sees or not, you should be honest to yourself. self. There should have some integrity. If you are having integrity, then you will not resort to all sorts of things. So the patient's comfort. Patient comfort is the main criterion for the doctors, whether it is allopathy, Ayurveda, or any other thing. You should have openness to accept our failures. If you say that, we give the patient with a lot of NSAIDs, all the medicines are not gastric friendly. It irritates the stomach. They come with the next dose, sorry, I am having stomach ache. You gave one medicine, I didn't sleep yesterday. So I always, to be on the safer side, I always add some PPI, that is omeprazole, pantoprazole, like that. So that gives immediate relief. See, these are all the extra-articular manifestations and vasculitis in so many severe forms. Nowadays it is not so common to see with vasculitis and iridocyclitis, episcleritis, and it can produce keratoconjunctivitis, Zika, and it can involve pulmonary system, pleural involvement, and alveolus obliterating bronchiolitis, and splenomegaly, neutropenia, cardiac involvement, and renal involvement, secondary amyloidosis, and neurological involvement. Anemia is usually normochromic and normocytic. If you are a good pathologist, you can see the cell and you can diagnose what is the type of anemia. This anemia is not normally responsive to any iron therapy. It is very, very resistant to normal oral hematinics. We give only intravenous if it is less than 9 or 10. If it is above 10, we give oral hematinics, and sometimes with good food. And once if you control the activity of the disease itself, the hemoglobin and other thing picks up. Regarding the treatment modalities, see, we have to educate the patient. We have to educate the patient in group counseling. We can conduct a group counseling. You give a severe cases, mild cases, moderate cases, you divide into group. Ask them to come on a particular time. You give a patient-to-patient contact. Then only they will have an interaction that will give a sense of confidence. They will not get depression. They will have a sense of confidence, and they will come up with they will interchange. And I have a different story to tell regarding the etiological factors. One of our old patient, a Muslim patient, came to me that she has seen all the rheumatologists, Ayurvedic practitioners, homeopathic practitioners. Finally, she came to me. I was talking to her for about half an hour regarding the food habits. What do you do in the morning? What do you take in the morning? Breakfast and other things. And she was telling, I am very much fond of taking these bananas, and especially this sevvalai, which has got the highest serotonin content. So I asked her to stop taking this sevvalai palam, that is banana. Next week when she came, she was totally relieved. But the time when she came was in a mild stage. No synovial involvement, gross involvement. Nothing has happened. When I took X-ray, it was almost normal except for a periarticular erosion. Everything was normal. She was immensely pleased. She came and thanked. You have cured. No, I have not cured. I have only educated. Since then, the patient was leading a normal life. This is one story. The another patient, he was a driver to the PA2 collector. And that lady collector, he used to take him to wherever he goes, he used to take him as a driver. And I have seen so many occasions because of the non-vegetarian intake that triggers, that is precipitating factors, that triggers the autoimmune reaction. So I advised him not to take. And he was free for about 5 to 6 years. Because the collector persuaded him to take that biryani, he took it. The next day he landed up. Now I told him that this is the culprit. Hereafter don't take non-vegetarian. See, these are all the small intricacies which we fail to understand. So the food habits and sometimes the flavors. It can be anything. Some mental stress can aggravate and it can lead to the vicious circle of producing degeneration and destruction of the articular cartilage. Because the articular cartilage has less potency to regenerate. It is not going to regenerate. It is going to be replaced with only fibrous tissue. As I said first, the articular cartilage is not sensitive. It is not sensitive to pain. Once if the cartilage is eroded by the way of subchondral erosion and disintegration, fibrillation, there are so many degrees of articular damage. If it is fibrillated, the underlying substance, if the subchondral bone is exposed, it is highly vascular. That is the reason the patient have severe pain intensity. So you give a rest to the joint. You have to give a splint, night splint. There are so many modalities available in the physiotherapy department. You can have wax bath in the morning, you can have IFT, and you can give TENS, whatever may be the modality. Shortwave diathermy, that shrinks the swelling of the synovium. We normally give diclofenac, naproxen, indomethacin, of late the selective COX-2 inhibitor, etoricoxib. Etoricoxib is available and it is prescribed 1 OD dose. And it gives a good support. And you have to combine with some omeprazole tablets like that. So once the patient has got some relief of pain, that is almost the patient wants immediate and instantaneous relief, which you cannot expect in DMRD and Ayurveda or Siddha, whatever it is. So once the patient is convinced that you are capable of dealing the pain, you gain the confidence of the patient comes to you for a periodical visit, whatever you suggest, he listens. If you are not going to deal the pain first, he will go in search of another doctor. That is human psychology. They will go like that and you cannot blame them. If anything comes like this, I will also try to get the best doctor, whatever may be the fit. As Dr. Bhaktivachalam was telling, his wife is suffering from rheumatoid arthritis. He went to Dr. Narayanan. Narayanan only saved. He has got sleep. So similarly, whatever may be the modalities of treatment, you have to accept and you have to follow. And we have got a moral responsibility. The patient has got confidence and we should not betray them. We should live up to the standards. And slow acting, I have purposely added slow acting means it reminds me once and again that it is slow acting. I cannot fully depend on DMRDs first. So we now start the patient on methotrexate. The commonest thing we do on methotrexate, 7.5 to 10 milligrams weekly. The next day, it is working against folic acid. So you should not combine folic acid along with methotrexate. You have to give folic acid the next day, not on the day one. It impedes the effect of methotrexate. Weekly, 7.5 or 10 milligrams. You increase slowly so that this acts on the synovium and reduces the synovial swelling. It reduces the synovial swelling. You can see when you treat the patient for about 4 to 6 weeks, you can see. And it should be combined with hydroxychloroquine in a dose of 200. All these medicines, they are having some side effects. No medicine in this group has got no side effect. Every medicine has got side effect that you have to depend upon and you have to titrate again against the patients who are having minimal thing. Sometimes very rare this is ocular disturbances are encountered with hydroxychloroquine, and sometimes methotrexate can produce alopecia, but we have to tell the patient about the potential hazards of the drug, and we have to explain them. Otherwise he will get panicky and he will start running from you. He will go to some other place. And Leflo, it is started in 20 milligram. And these immunomodulations, we don't have much experience, and we don't nowadays use immunomodulators, azathioprine, cyclophosphamide, cyclosporine. And recently, it is going to replace this methotrexate, Armamact. It also comes under this biological this thing. So it started at 100 milligrams once daily. And steroids. Why I have depicted in red color is you should rarely use steroids. It is addiction forming, it is dangerous, it is going to slowly kill the patient before the disease itself kills. So very rarely we should use. And if there is any enormous swelling of the knee joint or this knuckles, that is MCP joint, proximal interphalangeal joint. In osteoarthritis, the distal interphalangeal joints will be involved, whereas in rheumatoid arthritis, the proximal interphalangeal joint and MCP is involved. Nowadays, it is very, very rare to see all this Botanier deformity, ulnar drifting, because the patients are well informed. They go to medical shop, take some medicines, so it's certain extent it curtails the disease, it stops the disease. So steroids we normally use with minimal dose. We have a bridge therapy, that is DMRD, any DMRD with hydroxychloroquine and methotrexate with COX-2 inhibitor plus prednisolone. Prednisolone one dose, it should be less than 6 milligrams. If the severity is more, you can increase up to 60 milligrams prednisolone, and you have to keep the disease to a normal level so that the patient will not feel the symptoms of the pain. Then you gradually taper, otherwise you will have a rebound pituitary axis phenomena. So we give very rarely, but those who have already been on steroids, and they rarely accept for tapering the dose. And sometimes, because it's an autoimmune disease, I have a patient right now with myasthenia gravis and rheumatoid arthritis. That girl is about 18 years. 18 years, she is terribly upset. Though I rarely take up that challenge, I can treat. Still, I have given her hope that she should keep coming. So I inquire about the nature of work and other things, so that to give some support, whatever may be it is. Either at the working spot or at the learning spot, I can give some suggestions, I can give some guidance so that the patient is somewhat relieved mentally. Recently, I think you would have seen all in the Hindu paper, there was an article by Dr. Krishnamurthy, the mind and the disease treatment. So we have to read the mind of the patient, you have to give some sort of comfort. Then only the success of treatment will progress. Otherwise, you will not have any success. And physiotherapy. Physiotherapy has got a wide role. Since the inspection, if you diagnose as rheumatoid arthritis, you have to always incorporate a team so that the physiotherapist will give exercises. The socio-economic status has improved. Everybody wants a vehicle, even to travel half a kilometer, which they have been, which in 50 years ago, everybody was walking about 10 kilometers to go to school. Nowadays, they want a school by the neighbor house. So the lifestyle has changed. The disease has changed its lifestyle of attack. So you have to incorporate a physiologist. And these are all the types of management. If there is a subluxation in the elbow, wrist joint, you have to stabilize. These are all the modalities it is available. And you can have a knee replacement, hip replacement, shoulder replacement. But everything is secondary. The God has created with all fineness in creating all each and every structures. You cannot say that this is a waste. You cannot say. The God has created, and you are so kind enough to have everything, and you should live a life as you see in the slide. Thank you for giving the opportunity. I thank the organizers. Thank you very much.